Dr. Amina. So good afternoon, everybody. Welcome once again to these webinar sessions on social health insurance for Kenya. Our usual moderator, Dr. Amina Goulet, she's not able to connect. She's experiencing connectivity problems. So we will start with the webinar while we're waiting for her. My name is Georgina Bonet. I work at WHO, and I will be supporting this moderation. And before starting, just wanted to make sure that all the speakers are upgraded. I want to make sure if Dr. Tabitha Okech is already upgraded as a speaker. I hope so. Otherwise, let's start. I will introduce, first of all of our speakers. We have today representation from the Philippines, as well as from Brazil, and WHO as well headquarters. So we will have at the beginning a presentation from WHO Geneva, our colleague Althea Citruk. She works at the Department of Health Economics and Evaluation. After that, we will hear as well the case of Kenya, what we are doing on health technology assessment. And for that, we will have a presentation done by Dr. Tabitha Okech. She is a dedicated HTA research fellow at the University of Nairobi at the Center of Epidemiological Modeling and Analysis, SEMA, and she has experience in cost-effectiveness modeling and evidence generation for policy decision making. We will also have Dr. Mwei that will support and contribute to this discussion for Kenya. Dr. Valeria McCory, as usual, the head of the health financing at the MOH unit. She will also be part of the discussion. And then from Brazil, we will have a presentation from Dr. Barbara Pozzi. She's advisor to the Ministry of Health based in the CONITEC, is the National Committee for Technology Incorporation that has a mandate to provide recommendations to the MOH Brazil in the incorporation or the investment of health technologies into the public health system. And then in the case for Philippines, we will have Dr. Anne Mafori. We also call her Dr. Yen. She's a pharmacist and is the Chief of Health Technology Assessment Division at the MOH in Philippines. She will be also interact, and we will have Dr. Jacinto Manturing, also called Dr. Jojo. He will support answering questions and provide some insights. He is a professor of clinical epidemiology and clinical pediatrics. And aside from that, he has also a lot of experience as a physician in both areas, but he's also the HTA Council chairperson in the Philippines. So this is the introduction to our session today and to our speakers. And without further ado, I will give the floor to Althea from WHO to kindly introduce the topic of today. Thank you very much. Oh, I think I forgot to mention what is the topic of today. Apologies. So we are discussing today on how making better healthcare decisions, understanding health technology assessment, and its role in shaping social health insurance coverage. Thank you. Althea, please.
Thank you very much, Georgina. Let me share my screen as I have some slides that I would like to present. I hope you can see my presentation. I will be discussing today the topic of HTA institutionalization, what we mean by this, how it's linked to health benefit packages, and what we know from the WHO side based on the work we've done with countries on country experiences. First of all, to make the link between HTA and health benefit packages. At WHO, we see this as supporting countries to adopt an approach for health benefit package decisions that are driven by data and dialogue with an institutional basis at each step. So within the first...
Altea, please, we are seeing... Yes. We are not seeing the presentation in slideshow. We are seeing your screen. Thank you.
Okay, thank you. Let me try again.
Yes, that's great now. Thank you.
Thank you. So within the first stage, the data analytics are happening based on locally specified or nationally specified criteria. Then the next stage is the dialogue, which is informed by the data, the deliberative dialogue process. And finally, the stakeholder dialogue then makes a recommendation to the decision maker. We look at the HTA process as the process that allows us to put this 3D approach in place to inform the benefit package development process. What is meant by HTA? HTA is not limited to one type of health intervention or technology, but it covers the entire range of technologies from medicines to vaccines, medical devices, interventions, and service delivery. I'm not sure why my slides are advancing by themselves, but sorry about that. All right. What do we mean by HTA institutionalization? What we mean is that we look at several elements to understand whether HTA is institutionalized or how HTA should be institutionalized in the country. So first of all, we look at the enabling environment. And there are several elements within this, including the political demand and support for HTA, the governance structure and the institutional arrangements, as well as the legislation that is in place. Then we look at inputs into the HTA process, the existence of technical skills and capacity, data availability and quality, and the funding for HTA. Then in terms of the process, whether there are established processes for HTA, whether these are participatory processes, to what extent stakeholders are participating, and whether there's transparency and accountability. And then the last group of elements that we look at is the outputs, outcomes, and impacts of HTA. So the quantity and the quality of reports that are produced, whether there's an impact evaluation, and whether the decisions are being revised. We have looked, as I said, at country experiences with the institutionalization of HTA through a number of efforts. One that is shown here on the screen is the global survey on HTA and health benefit packages, which was done in 2020 and 2021, which was sent to all member states of WHO, and to which 127 member states responded. And then we also did 23 in-depth case studies in 2023 and 2024. So now in the next part of the presentation, I will focus on giving you some highlights from those two efforts, what we found that countries are doing that can hopefully be useful to Kenya as you are thinking about this process. So first of all, from the global survey, what did we find out in terms of institutions and governance of HTA mechanisms? We found that 102 out of 127 countries that responded have a systematic formal process to gather information to support decision-making, regardless of whether they call this HTA or not. Because it's not called HTA everywhere. But for the countries that do have such a process, most of them are gathering information to support a few key functions. First, planning and budgeting, clinical practice guidelines, and the design of benefit packages. Those are the three main ones. Then what we found about the assessment and appraisal processes, in most cases, the Department of Health or Ministry of Health was responsible for nominating interventions to be reviewed by HTA. Then we asked also in the last year how many assessments were performed. As you can see, the number in most countries, it's below 100. There was a mean of 65, but there are some outliers, like all the way up. You see the one you see there that produced over 900 in 12 months. That was France. And then we ask also how long does the assessment process take on average for any given intervention or technology. And in most countries, that was 3 to 6 months. Then we ask also about barriers to production and use of HTA. And in terms of barriers to production, the number one ranked barrier was awareness and advocacy. The second one was institutionalization of HTA. And the third, the lack of qualified human resources. Then in terms of barriers to use of HTA, we found that the main barrier was dedicated HR and budget availability, then also data availability and the knowledge of methods. So now going a bit more in depth, looking at what we found from the case studies, which looked more in depth at this question of HTA institutionalization, and going through some of the main criteria that I mentioned before that we look at to determine if there is HTA institutionalization. So on the question of political demand and support, we can see that in countries that have well-developed HTA, there tends to be widespread and sustained awareness, not only among policymakers and health professionals, but even in the general public, as opposed to countries where this is developing, where the awareness remains limited to few stakeholders, especially in terms of public understanding. But countries that are working on developing are also working on building awareness. Then in terms of political support, again, countries with well-developed HTA tend to have stable political commitment, and HTA is well integrated into government policies. So not only there is political support, but it's not fluctuating with political changes as we see in countries that have weaker political support. And then another key element here is that in countries with mature HTA systems, we tend to see that they make independent decisions as opposed to those with emerging HTA frameworks, which tend to rely more on external partners or donors who drive prioritization. So how is HTA governed? What are the institutional arrangements? That was another element. In countries with advanced or mature systems, they tend to have formal, legally mandated processes for HTA that systematically evaluate health technologies, and others are lacking such formal processes or have partial mechanisms or structures in place. Again, in countries with strong HTA processes, we also see that HTA plays a decisive role in determining coverage of medicines, devices, procedures, etc. Whereas in others, they may not be directly connected to decisions on benefit package or coverage. And in terms of allocation of responsibilities, the governance structures also tend to vary. In some cases, there are organizations that oversee all the key functions. In others, the responsibilities are distributed among different entities. And in many cases, countries are starting with pharmaceuticals. It's the pharmaceuticals that receive the most attention in HTA evaluations. And in terms of clarity of roles and responsibilities, we see in well-established systems, the roles of different actors are clearly defined and often institutionalized through legislation and procedural guidelines, etc. So to what extent is HTA supported by a legal framework? In countries where HTA processes are well established, we tend to see that they have strong legal frameworks to support this. Whereas in countries that don't have formal frameworks or are developing, we see that either they don't have the laws yet, are working to develop the laws, or in some other cases, some laws may be there, but they are not enforced. And then how is HTA linked to coverage decisions? We see that this also varies. In some countries, there are mandatory considerations. So HTA is legally required for benefit package design, and in several cases, it must be followed for reimbursement. In others, it's not legally binding. It has to be considered, but it's not legally binding, and decision makers can override recommendations. In terms of technical skills and capacity, the workforce size varies as well. So in countries, again, that have mature systems, we see that there are often large teams with dedicated agencies for HTA, specialized divisions. And then this can range in other countries with smaller teams to countries that have minimal capacity, less than 10 people, who are often doing other jobs in addition to being responsible for HTA. And there's also reliance on external experts. In terms of education and training availability, we also see variation from countries that have established programs at the master's or PhD level in HTA, health economics and policy, to others that have maybe lower level degrees, diplomas, integrated courses in other degree programs, to short courses, workshops, and then also on-the-job learning and ad hoc international courses. I mentioned data availability, which also was highlighted by countries as a main barrier to carrying out HTA processes. This also varies greatly. Again, in countries that have mature HTA, we see that there tend to be strong data infrastructure, while others are struggling with inaccessible, unreliable, non-existent databases. In particular, economic and costing data are often scarce. But what we see also is that countries that have strong domestic and international partnerships tend to have better access to data, especially HTA networks, universities, and global agencies are good resources for supporting data exchange and evidence synthesis. Also, use of international data is common. So many countries are adapting HTA evidence from other countries due to local gaps, but there isn't an agreement on textualization methods. So these tend to vary. And then lastly, public access to data is also varying. Some nations provide transparent cost databases. Others have either restricted access or do not have such databases in place, but we see efforts to create national cost databases in several countries. In terms of funding for HTA, who funds it? Public funding varies. Some countries have dedicated HTA budgets, which ensures stability. And then we see in those countries that this also tends to link to the availability of staff that I mentioned earlier as well, and the data. We see that budget constraints are a barrier in many settings. Countries with stable funding produce regular HTA assessments, whereas others may be more ad hoc depending on when funding is available, and some are struggling with chronic underfunding. We see also models where private funding plays a role. Many countries prohibit industry funding to maintain independence, but we see some allow private funding from research institutions and insurance companies, and a few rely on private sector contributions. Then we look at, are there established guidelines that outline the HTA process? So some countries have structured guidelines and manuals, whereas others are more fragmented or evolving. Economic evaluation guidelines exist in some settings, but they are usually not standardized. And evidence appraisal processes also range from more formal processes to informal reviews. In terms of whether there are rapid evidence assessments processes, we see that some have rapid processes for non-emergencies, but during COVID-19, we saw that a lot of countries did expedited assessments, but did not really have formal HTA, emergency HTA frameworks, and had to adapt. So in terms of coverage of health technologies, pharmaceuticals are most often covered by positive lists, whereas for other technologies like medical devices and procedures, those are more likely to be subject to some form of implicit rationing. Finally, an aspect that I wanted to highlight that came out from the case studies was also the social participation aspect, whether the HTA process is participatory. And here we found also that stakeholder involvement varies. In countries that have developed this aspect well, we see that diverse stakeholders are included, including government, insurers, health professionals, civil society, and patient groups, but others limit participation only to government-appointed experts, where this aspect is less developed. In terms of how appraisal bodies are composed, the representation depends on which type of health technology is being evaluated. So there are different compositions for different technologies. Members are often appointed by government agencies, ministries of health, or national agencies. Some systems grant all members equal voting rights. Others give decision power only to select representatives. And public consultation is allowed in some settings, but absent in others. And in terms of the decision-making process, some, not all countries have separate decision bodies.
Althea.
Yeah, this is my last slide.
All right,
Georgina.
thank you.
Yeah.
Thank you.
And stakeholder inclusion also varies across intervention categories. Again, with the decision-making process, ministries or government agencies typically appoint the decision makers. And some systems ensure equal participation in decision-making. Others give more authority to government representatives. This is all from the case studies and from the survey, and I'm happy to answer any questions. Thank you.
Okay, thank you very much for this introduction to the topic and explanation. What is health technology assessment about? But on interest of time, let's move now quickly to the Kenyan team for them to explain how it translates for Kenya. How do we understand this process of preparing evidence-based, transparent decision-making to support design of benefit packages and how it will translate in the reforms that we are doing now. On interest of time, because we have still the examples of 2 more countries, I would ask the Kenyan team to go straight to the point. And thank you very much. The floor is yours.
Thank you, Georgina. Good afternoon, good evening, good morning to our other colleagues from Brazil and Philippines. I would like to talk about the institutionalization of health technology assessment in Kenya. And mostly, sorry, my slides are not moving. Okay. I will focus on the inputs and resources that are required for HTA and what is currently available, what the enabling environment to strengthen and institutionalize HTA in Kenya is, what the HTA processes are envisioned to be, and mostly this is based on the regulations that are already available and how we propose that HTA results would be produced for Kenya. So on the inputs and resources, Kenya has done so much, and progressively there have been legislations and regulations that one way or another are going to support the institutionalization of HTA. And I will elaborate more in the next slides on that. In terms of institutional support, there is political goodwill to institutionalize HTA with the transition of to social health insurance. There's already frameworks that are being set up for collaboration efforts, both nationally and internationally. And even like within the country nationally, the regulations themselves give room for collaboration between public institutions, as the university, as academician and evidence generators, and the Ministry of Health to generate evidence for through HTA for this kind of work. In terms of data and information availability, I like that Altea has talked about, the importance of availability of data and the quality of that data. Although we have data scattered all over, there is data here and there. And there's also need to still generate that data. The university is putting in efforts to bring together clinical data. So that's access to healthcare data, healthcare utilization at different levels, the primary healthcare and tertiary healthcare, and how that affects health resource allocation. Also, there's need to provide epidemiological data, that's the burden of disease data. So there's estimations of burden of disease, or there's data that we can use to estimate burden of disease, but we are putting in more effort to provide this data and collate it for use for HTA processes. Costing data also is a big challenge, how to cost or the cost of the different health technologies that are probably considered for reimbursement or for use in our country. The university is also in the process of putting together costing menu, if you'd say, or a costing reference database that then we can use for HTA processes. So still, there's a lot of laying of foundation for to put this data together. And there's still more that needs to be done. And hopefully, when all this data is put together, it will be available in a health information system. And modalities on, access to this data will then be discussed. And of course, the stakeholders will have to agree, and the ministry and the government will also guide. We also have, I think, policy on data sharing, and accessibility, and that will also be considered in availing some of this data or not. And then in terms of methodologies and guidelines, yes, we still do not have, standardized guidelines or HTA process guidelines for us to be able to chart the path forward. But the vision is, as we institutionalize HTA and as we lay down the processes, hopefully Kenya should be able to have a reference case and, use that to design the HTA methodologies and guidelines to conduct HTA processes for the different health technologies as we go by. And that will also, also inform to have, standardized templates for the different health technologies, be it medical devices, be it vaccines and medical processes, whatever it could be. Altea talked about, economic evaluation frameworks and, some countries not having standardized frameworks that are for the country. Hopefully we can learn from those who have it and what benefit it has had for them. And hopefully Kenya can also, have an economic evaluation framework that guides and, gives a threshold for the economic evidence that we'll produce for the HTA process. We also need to think about, the mechanisms and communication strategy for stakeholder engagement that then will inform the HTA process. How do we hope to involve patients as stakeholders in the decision-making process, the civil society, the professional bodies, and all that. This is supported in the regulations, and so it makes it easy to now chart what mechanisms can be used to engage the stakeholders in a HTA process. There's still, infrastructure that needs to be put in place. The regulation provides that the HTA process will support development of the benefits package, and that that structure will be supported by a public university and the Ministry of Health. That means there needs to be some administrative structure put in place, and the setting up of that structure is in process as we speak. Also, Kenya needs human resource. So we have, a few people who've been trained on health technology assessment. We have a couple more people who have been trained in HTA domains, so health economics itself, epidemiology, equity consideration, social sciences, actuarial science, but there is definitely still need for much more training. Different stakeholders, even the University of Nairobi has offered, short course trainings on health technology assessment, but there is still so much demand, there's still so much need to train so much more so that everyone is on board and understands what the HTA process is and how it informs decision making. And with that, of course, there's requirement for financial resources and consideration for the government to allocate operational and, HTA research resources, but also a call to, partners, development partners, and, stakeholders to be able to finance the HTA process for us to realize institutionalization of HTA. For capacity building, I think I've talked about the training programs that we have at the university for HTA, and also other collaborators. There's been trainings on health economics, I think, carried out by different institutions, including Cambridge. There's need for, mentorship programs on HTA for Kenya to be able to do this work. So looking at the legal framework and probably a bit of history. So before the 2000s, there was limited formal health technology assessment, even in terms of demand itself. And then going on when there was reforms that were required for the National Health Insurance Fund, there was growth in terms of, membership. There was expanding membership. There was demand from the membership to expand the benefits package, to expand, the service entitlement in the benefits package. And with that, a challenge arose on, cost containment and, decision-making process. So which services are going to be prioritized for reimbursement with the funds that are available. So with that need and, with that pressure and growth within the NHIF then, this resulted in amendments on, the NHIF Act severally to be able to accommodate the needs of the members, the growth of the fund itself over a long period of time. Additionally, with that, I think in the beyond 2010 and thereabout, Kenya also worked on the Kenya Health Policy, which provides a regulatory agency or regulatory framework for institutionalizing health technology assessment. So health technology assessment over time has grown into several policies, several regulations that supports it one way or another. We have the National Pharmaceutical Policy, which talks about, affordability and pricing regulation for medicines itself. So it talks about, setting up medicines pricing and affordability advisory committee that then advises government on affordability of medicines itself. We also have the Health Act 2017, which recognizes the role of health technology assessment in supporting financial decisions on health. And this is the legal basis for HTA institutionalization for Kenya. With this act, there are several policies. So we have the Kenya Universal Health Coverage Policy, which emphasizes the need for equitable access of effective, affordable, feasible health technologies and culturally acceptable, health interventions as well. We have the Kenya Community Health Policy, which also aligns, talks about, when you talk about community health, it guides on how community health would be implemented, but it also addresses the equity issues in access to health. And so with the provision of community health services and with the provision of primary health care, with the provision of emergency medical care, and now we're talking about social health insurance, how do we prioritize resource allocation to all these, different sections that actually tie up together to provide health? So health technology assessment definitely will cut across and will consider all these policies and what they address in terms of health. And then we have the Social Health Insurance Act that then gives the mandate for the Social Health Authority to transition from NHIF. And with that comes the regulation. So the social health insurance regulations gives us a nice framework and actually outlines the process, the HTA processes, how they will be implemented, and establishes the HTA Secretariat and the Health Benefits, Tariffs, and Advisory Panel that then will implement or will provide decisions, provide evidence that will be used to make decisions on developing the benefits package. So the legal framework is in place largely. There could be areas that may need to be reinforced, but generally this shows that Kenya is really ready to institutionalize health technology assessment. So from the regulations, I teased out what the governance structure should look like, and this could change with time, but basically because it's anchored in law and most of it is anchored in law, this is what will inform what how the health technology assessment will be institutionalized in Kenya. So there will be a National Health Steering Committee with representation from the Ministry of Health, academia, research institution, healthcare providers, payers, and patient group and development partners. And this is a strategy. They'll provide strategic guidance and oversight on health technology assessment programs. So the committee then also will get information or evidence, appraised evidence for consideration from the Health Benefits and Tariff Advisory Panel. So Health Benefits and Advisory Panel, the regulation outlines who will be the members of this panel. So there's a chairperson who is from the host local public university. And then there are other stakeholders, including the Director General from the Ministry of Health, and nominated members will be nominated by the Cabinet Secretary, including specialists in epidemiology, health economics, actuarial science, and then representation of stakeholders from the professional bodies, from civil society, patient groups, and all that. So I think there's just this week, the Cabinet Secretary, actually yesterday, the Cabinet Secretary outlined that the Ministry of Health has already established who these panel members are, and that's a step in the right direction. This panel will be advising the Cabinet Secretary and the Social Health Authority on what interventions will be reimbursed in the benefits package or will be included in the benefits package. And I believe this will be progressive. So we are waiting to see what this will look like. And the panel definitely being a constitution of different stakeholders, Ministry of Health being one of them. So it is not clear what the structure of the ministry will look like. So it could be a HTA program, division. I think in the legislative framework, probably it should be the Kenya Health Policy, which talks about the HTA agency as a regulatory framework for HTA. So we are hoping to see how that will pan out. This will be the coordinating structure for the HTA activity. So linking both the panel and the secretariat. And then we have the National HTA Joint Secretariat, which is provided for in the regulation 2024, the Social Health Insurance Regulation. So the Joint Secretariat has representation from the Ministry of Health and the host university. And this is the technical and secretariat support to the panel. So this is the coordinating body for HTA processes. And hopefully this is the secretariat that then brings the HTA doers and HTA users together. So for there to be a HTA network who the guide on who will provide which evidence, how the topics will be selected, who selects those topics, which ones will be prioritized at what time. So yeah, this is a body that will need to put together and make sure things take off. Looking forward to that. And then also in the regulations, we have the selection working groups. So although not defined on which selection groups we will have, the selection group could be the economic working groups, could be medicines and vaccine working groups, medical devices. And we are going to learn this from the countries that have implemented HTA and see what works for Kenya. So these selection groups will review the interventions proposed and select the intervention that shall be subjected to assessment. Yes. So this is roughly what the government structure should look like. It could vary a bit, but this is what the proposal looks like. So also in the regulations outlines clearly what the HTA process will be in Kenya. And I summarize this very briefly into who will propose the intervention. So the stakeholders are envisioned to propose what interventions should be considered for assessment for the HTA process. And the stakeholders, I think we very well know the stakeholders would be including even the patients themselves. And then it also outlines that the selection of interventions, once they have been proposed, will be done by the selection working groups. So if we have 100 proposals to be considered for the HTA process, then how do they select which interventions are going to be considered for the HTA process? And also, actually, it outlines, as you propose the intervention, what evidence do you need to provide? So whoever proposes an intervention to be considered for appraisal or inclusion in the benefits package, then needs to provide clinical evidence, needs to provide cost effectiveness evidence, budget impact evidence, and so on and so forth. And there's actually a template that is already provided for that. And then the selection working group then selects which topics will be appraised because there's adequate evidence, and which ones will then need to be assessed to provide more evidence where evidence is lacking during proposal. And so with that, then it guides on what assessments will need to be carried out. So there'll be need for clinical effectiveness evidence, cost effectiveness evidence, equity considerations, what the legal implications of considering certain interventions will be, and this will be done by the HTA doers. So the academicians, the research bodies, and hopefully there can be a health technology assessment network that involves, everyone who is able to provide this, to generate this evidence for consideration to the panel. So then once this evidence is generated, and there's actually timelines that the regulations provides when how much time each of these steps should take. And then the panel then is provided for to sit twice a year to appraise the intervention, the assessment, and the evidence that has been provided, and then write a HTA report and provide those reports and policy briefs for consideration to the cabinet secretary. So the cabinet secretary, in the consultation with the Social Health Authority and with the available resources, then sees which intervention gets to be included at what point in the benefits package. So I think this process, although it may look like if we provide evidence, then the evidence should be considered because it is cost effective, an intervention is effective, it meets equity considerations and all that. But I think as we are learning, and I think Altea also spoke this out, the HTA process is an evidence providing process, but it doesn't mean that, for all the evidence that finally gets put on the cabinet secretary's table, then gets adopted. There are also other considerations on, what funds are available, what can be prioritized now, like what is the immediate need, do we have public health emergencies, and what resources do we have then to consider interventions at this point and not and others at a later point. So the evidence,
Savita,
the results, yes.
Sorry to interrupt, please, 1 minute.
Yes, I think this is my last slide. So for Kenya to produce results for HTA, Altea already showed what the this process would look like. But so for Kenya, for topic identification and prioritization, this proposal to do horizon scanning for interventions that need to be considered for Kenya, and then also topic selection from the suggested topic from stakeholders, and then with those topics that are then identified and prioritized, there will be evidence that will be gathered through several processes, including literature searches, critical appraisals, and other evidence synthesizing methodologies, including assessment and research. So there could be clinical effectiveness research, cost effectiveness research, safety researches, ethical considerations, depending on what is required for those health technologies. And with that, the generated evidence will then need to be put in an HTA report for recommendation and consider and appraisal to the panel. And then Kenya, we still need to come up with what our dissemination strategies will be and our communication channels to different stakeholders. So how we communicate to the patient groups may be different from how we communicate to policy decision makers, and that we'll need to chart out a path for that as well. And then also there will be need to conduct an impact assessment of the HTA process as well, and evaluate the process as we go, and keep reiterating that process. Asante sana.
Thank you very much for that, and all the passion that you put in explaining where we are in Kenya. We already have this legal framework and political will, which is the foundation to continue to this journey. I remind you that please, you can put more questions in the chat. Also, the speakers can go to the chat and answer some of the questions, because the time now is becoming short. We might not have enough time to go live in answering all of them. So I will give the floor now to the team of Philippines. Also, there is some, I wanted to, while you're explaining, there's questions in the chat on what exactly is this HTA used for? Why do we need it? Why, what gap is actually filling in? Why do we introduce this HTA analysis? So please, the floor is yours, Dr. Yen. Thank you very much.
Very much, Dr. Georgina. Good evening, everyone. Good evening. Well, good evening from the Philippines, from Manila. This is the Philippine experience and situation of where we are at the moment after 5 years of institutionalizing the HTA system that we have right now, and where are we heading to exactly. Before I continue, may I confirm if I'm clear? If my audio is clear? Thank you so much. All right, so let me begin with this brief encapsulation, visual encapsulation of the history of HTA in the Philippines, which essentially shows us that while the recognition and the demand to integrate HTA in the Philippine health systems started quite early, as in early 1990s, the elements to make it viable and sustainable in the Philippines weren't really there until about 20 years after, when finally the Philippines passed the Universal Healthcare Act of 2019, which included very important provisions on how the Philippine government is mandated to commit to establish a system of HTA in the Philippines and how it will be part of the operations of the health systems towards achieving universal healthcare. So these are basically the summary of what the law, the Universal Healthcare Law of the Philippines states about HTA in the Philippines, and I will be covering some of these in the next coming slides. So the first one is very important because it sets the tone of the role of HTA exactly and how it will be placed in the grand scheme of things. So it is very explicit in our Universal Healthcare Act that HTA will be a priority setting mechanism that will be recommendatory to our Ministry of Health and to our National Health Insurance or PhilHealth in guiding or in creating any coverage decision. And similar to how HTA is placed at or structured in many healthcare systems around the world, HTA is placed after market approval, specifically if this particular technology that has been authorized by the regulatory system is something that we want the Ministry of Health to introduce through the public health programs, national immunization program, or something that we want to list in the national formulary, or maybe as part of the benefit packages of our national health insurance. Our law is also very explicit that the HTA system that will be created should be managed by a multidisciplinary independent expert committee. So this committee is called the HTA Council. It was first created in 2019 under the Ministry of Health. It's composed of 30 members. So it is a two-level council composed of the core committee, which if you will see the membership, it represents the different fields of expertise in HTA. And under them are 7 subcommittees who are experts on the different kinds of technologies. So these are also the names of the subcommittees here are also the remit or the scope of what kinds of technologies are required to undergo HTA in the Philippines. I think what's worth highlighting in the HTA Council of the Philippines is that within the core committee, we have a sitting voting citizens representative as part of the usual experts, the clinical epidemiologists, the health economics person, and the rest of the other academicians that you would usually find in an HTA committee. So of course, their main task is to issue or provide coverage recommendations on whether a particular technology under appraisal or that had undergone HTA should be financed by the Ministry of Health or by the National Health Insurance Corporation. So the law is also explicit that these will be the basis of the council in making their recommendations to say whether a recommendation is positive or negative. So you can see criteria related to clinical assessments, burden of disease, economic evidence, and ethical, legal, social, and health systems implications. Another important provision in the law in the institutionalization of HTA in the Philippines is to create a dedicated support office for the operations of the council. So at the moment, we are calling it the HTA division. This is the office I'm heading. And the core service of this office is to produce HTAs or conduct HTAs that will be churned by the council and turned into recommendations. So we were created about 5 years ago, about around the same time when the council was created, probably 3 months before the council was created. We initially started under the Ministry of Health as a very, very small informal unit. We started with one person and then became 10 people, and then now we're about 28 people. So last year, we've also started working with external assessment groups to produce assessments for the council. These are groups that are coming from the academe or private research entities. So altogether, the outputs of the assessors, whether that's an in-house assessment from the HTA office or from the external assessment groups, these are turned into recommendations by the council, and these are issued to the decision makers. That's the Minister of Health, who makes the final decision based on the HTA recommendation. But it's a notable provision in our law is that the Ministry of Health cannot make any positive decision to finance any technology without a positive recommendation from our council. So in 2023, fulfilling another important provision in our law, the entire HTA Council and HTA Office transitioned from the Ministry of Health to the Ministry of Science and Technology. So we're not under the Ministry of Health right now. We are under a different ministry. And the intention in the law is to make sure that the process of HTA, the decision-making process of the council, will be independent and will be free of politics and conflicts of interests from its recipient, which is the Ministry of Health or the user of its evidence. So in 2019, 2020, during our very early nascent stage, our first core task force is to develop our normative guidances. So that's the basis of our operations. The process guide, which gives you the standard set of activities or steps and how the stakeholders can be part of these steps, the different templates, etc. Even how we conduct meetings, how we ensure how we declare and manage conflicts of interests within the HTA Council and within the HTA division, how we handle confidential data when we, for example, receive confidential prices from the industry. So all of these are in the process guide. Meanwhile, the methods guide, this is the standard procedures, the methodologies on how exactly would we perform clinical assessment, economic assessments, as well as ethical, legal, social, and health systems assessment. So this is the main Bible, both for the in-house assessor as well as for any external assessment group that we will commission out. Okay. So interestingly, when all of these were being crafted and created, all of these, of course, as you can see with the timeline, all of these happened during the pandemic. So in fact, I think based on our experience, the first kind of HTA that we learned to implement was really the non-traditional way of HTA, because we had to, of course, be agile during that situation. So majority, during our first 2 to 3 years, majority of what we're doing are really expedited HTAs. And it wasn't until around 2022 when we started doing the traditional HTA process that we know academically and theoretically. So I think uh, the entire experience was baptism by fire for the experience of Philippines, but in a way, it forced us to really deliver and operate right away, and be helpful during a situation where you really need evidence, which was during the pandemic. And I think that built public trust also to the people when during a time when we were introducing new technologies for them. So right now, these processes and methods guides are undergoing revisions, which would reflect our learnings from the previous years of implementing them. We're also benchmarking with the processes and methods of other countries, and of course, based also on the stakeholder inputs on how we can improve our processes better. So, in building and implementing our system, we try to ensure that the following ethos and principles that you can see here are all enshrined and embedded in our different steps in our process, the way we conduct the different steps of the process, the way we do the methodological assessments, with a vision of not just becoming an agency that is excellent and efficient, but also a system of HTA that is fair, fair in terms of how we produce our recommendations. And in that way, uh, the results are credible and well supported by the stakeholders. So this one is just a highlight of the different milestones of the Philippines starting from 2019. You can see here some fluctuations in the number of assessments and recommendations, but that's a different story to tell. But basically, um, we try to keep up every year with the number of assessments. Whether we're keeping up with the target number of assessments, no, at this point, not yet. There are still higher number of topics or demands to perform assessment versus the number of assessments that we can actually produce in reality. And I will show you later on the reasons why. So overall, as you can see, we leveraged and gained momentum from our core strength, which is having a legislation for HTA. That really helped us and uh, helped us reach where we are right now in terms of institutionalizing the system and putting everything in place. And that enabled us to put HTA rightly in place in the grand scheme of things, and that is well recognized by the different stakeholders. Right now, the governance is independent and at an arm's length relationship with the Ministry of Health. However, uh, just like the story of any HTA agency that's starting, our main hurdle remains to be our efficiency, the timeliness of our entire process, and the production of many assessments that really meets the current demand of the entire health sector. So in the coming slides, I'll be showing you these different challenges that we are experiencing right now that are really our hurdles in scaling up the operations. So first, technical challenges, limited number of HTA practitioners in the country. And I'm talking about both those that are part of the support office, as well as those that are practicing in the academe. Poor health information infrastructure and therefore lack of local input data needed in conducting HTA, and this is most especially true for costing data. Lack of technology-specific methodologies for non-drug, non-vaccine types of technologies, which is very important for the Philippines because, as you've seen earlier, it's not just drugs that are mandated to undergo HTA, but all the rest of other types of technologies, even traditional medicines. if that's something that we want to be paid for. There's limited awareness and appreciation among various stakeholders, and I think it's because during the time when we were starting and introducing HTA, it was the time of the pandemic. We didn't have the time and resources to market HTA to the public. So there was limited awareness about what we do. For operational and process challenges, there's difficulty. People usually underestimate the administrative administrative action points or responsibilities. It was difficult for us to be transitioning from one agency to another. We still continue to adjust to our new agency right now. So it's difficult to be doing all those transitions and being expected to, you know, operate technically as if everything is just happening straightforward. Lack of efficient mechanisms for external commissioning, difficulty in adhering to the ideal process timelines because the truth is that HTA is not a one-way process. A lot of it involves data collection coming from other offices of the government, even engagement with industry, with the academe. So if the process is affected by other stakeholders, then you cannot control the overall timeline. Uncontrollable challenges in the bureaucratic process because we operate within the government agency. Ongoing transition, retention of human resource. There's also limited budget for operations, lack of formal process to measure our impact on UHC implementation. And then for organizational challenges, as I was mentioning earlier, human resource not proportionate to the amount of workload. So every year, at least for the recent cycle of nominations, we received about 160 nominations. We continue to see a pattern of increasing nominations year per year. And we think it's a reflection also of them recognizing that the pathway for a technology to be covered by the government is really through the HTA process. The more they learn about it, so the more nominations that we expect every year. Meanwhile, we only have 13 in-house assessors at the moment. And we're not just talking about the problem of low number of in-house assessors, but also not all of them, majority of them are not holding permanent positions. So of course, there's constant hiring, retraining, and unsustainable HTA capacity overall. So with all of these challenges, these are our current direction. Definitely the core of our strategies are on strengthening HTA capacity. We want to establish a bigger HTA agency. The goal is a 110 position agency. And hopefully by next month, we will be getting a portion of this 110 position. We're also trying to establish an HTA research network with the academe and other private research partners where we can efficiently commission out researches and also implement HTA training programs so we can really create a critical mass of HTA doers in the Philippines. We're currently piloting nominator-led assessments. We're also trying to create local HTA postgraduate program. We're creating technology-specific methods guides, and we've released a few of them starting 2 years ago. Like we have a specific HTA guide for conducting HTAs for
Okay, I think we lost Dr. Yen. Hopefully it's all good. Okay, maybe we can proceed. We will then put some questions. Hopefully she will be back soon. So let's proceed. then give the floor to the next country, which is Brazil. Dr. Barbara Pozzi. I hope you are ready to explain the experience in Brazil and the work that it's been done by the Ministry of Health and CONITEC. Over to you.
Hi, everyone. Can you hear me well?
Yes, please.
Okay. I'm going to share my screen here. I'm not sure if I'm able to actually. Okay, here. Can you see it?
Yes, perfectly. Thank you.
Okay, so CONITEC is our HTA committee. I'm going to start giving you a brief context of Brazil's reality. Then I'm going to go through our process, how it is, how it was established and how it works now. And then I'm going over the challenges that we have and the main improvements that we've done during the past few years. So, well, in Brazil, we have this big challenge for it being such a huge country, both in area and in amount of people. So it is very hard for us to implement something nationwide. It takes a lot of coordination between different levels of government. Here and at the map, you can see the 27 states that we have, and it's over 5,000 municipalities. So we have over 5,000 municipal governments to articulate with and 27 states to articulate with, and they all have responsibilities with implementing public health system policies and technologies. So it is quite challenging. Going back to how it all started in 1988, our most recent constitution was published, and it set out as a constitutional right for the first time in Brazil, and thus it said that the state is responsible for providing this right. 2 years later, in 1990, our public health system was founded. We'll call it SUS, our Unified Health System. It is universal. And in 2011, CONITEC was established. We already had an HTA body before, but it was a bit different. So we have over 200 million people in Brazil, and a quarter of people have access to private health insurance, but everyone uses the public health system as well. So 100% use the public health system. They have both the systems, private and public, have services that overlap. So from primary healthcare to tertiary healthcare to high complexity healthcare, they have services that overlap, but some services are exclusively provided by the public health system. Vaccines, for instance, are provided for 100% of the people. HIV treatment, everyone is treated by the public health system. Hemophilia, also all patients are treated by the public health system. And also there are services like surveillance that apply to the whole territory and every product that might impact health. So we always say that not everyone uses the private health system, only part of the population, but that 100% of people use the public health system somehow. Well, as the country is fragmented into different government levels and different health systems between the private and the public, HTA has also this characteristic of being fragmented. So at the Ministry of Health, we have CONITEC, which carries out the HTA process for the whole country, but local health departments, they can have their own HTA process. For instance, a state might have a different epidemiological characteristics and be willing to have a specific drug or procedure only for them that would not make sense for the whole country, they can do it. Even hospitals, for instance, here in Brazil at least, hospitals were first to actually carry out HTA because they were willing to improve their management to make it more rational and evidence-based. So the embryos of HTA were really in hospitals. They can also have this HTA process. And at the private health sector, we have a specific agency, INS, which is the agency for insurance and health security plans. And they have an HTA process as well. They have a list of procedures and drugs that every private health insurance must provide to their users. So they have a different HTA process. I'm not going into it, but they do it. And even in some cases, health insurance plans might also have an HTA process as well to add to the list of INS to provide more drugs or procedures, or even to just make more rational decisions regarding the technologies they're going to provide within procedures. CONITEC's mandate, as Georgina mentioned at first, is to support the Ministry of Health in decision-making regarding technologies, health technologies, and also clinical practice guidelines, these two processes of incorporating technologies into the public health system or modifying the indication of that technology. For instance, we can amplify the indication to a bigger group. It is very linked to the elaboration and update of clinical practice guidelines, and CONITEC supports the Ministry of Health with all of it. So CONITEC recommends the Ministry of Health on the inclusion of health technologies and clinical practice guidelines, and the Ministry of Health makes the decision. It usually follows CONITEC's decision, but it can make a different decision, for instance. It never happened, but it has this prerogative. So how did we get here? I think this is something that in the experience of other countries, it's quite similar to what happened to other countries and even to what's happening in Kenya right now. There was a capacity building effort during years. It's not something that happens fast. You need researchers that are capable of producing HTA reports, people that are capable of interpreting it, and really with its data, making a proper decision, an evidence-based decision. It's not that simple to have people that are technically capable of doing so. So it all started back in the first decade of the 2000s, some discussions, especially at the Chamber of Economic Regulation of Drugs, CEMED, which is where we set price ceiling here in Brazil for drugs. They all go through the Anvisa's authorization which is the regulatory authorization. And afterwards, there's a price ceiling process, which also uses HTA. So they started these discussions there. And then there was the National Policy of Science, Technology, and Innovation, which went further, and it was set by the Ministry of Health. Then the Committee for the Incorporation of Health Technologies was created in 2006, and it was the first HTA body, the embryo of CONITEC, that we had. The Ministry of Health started funding postgrad courses and other sorts of courses in order to really enable the creation of a network of researchers, which was then launched in 2008, between 2008 and 2009. And there was then a calling for the implementation of HTA unities. To foster the creation of these unities, the Ministry of Health financed the creation of these unities. And then there was the launch of the National Policy for the Management of Health Technologies, which is when, which is where HTA is actually implemented within a policy, because the first policy here for science, technology, and innovation did not mention HTA directly, but here at the management of health technologies policy, yes, there was mention to HTA, and it was about the same time that CONITEC was created here in 2011. And also in 2011, there was the institutionalization of our HTA network, the network of researchers. So it all happened at the same time, because the idea is to have this network of researchers supporting CONITEC and guaranteeing that we have a long-term technical capacity in the country, researchers that are capable of conducting HTA and supporting the Ministry of Health, local governments, hospitals with evidence-based decision-making. So about our legal framework, we, in 2006, as I said, there was this embryo of CONITEC, and in 2011, CONITEC was finally created. After this maturation process within the first years of the 2000s, a senator presented a bill of law to create CONITEC by amending law 8080 of 1990. This is very important, actually, because that's the law that set the basis for creating our public health system. And modifying this law guarantees that CONITEC is directly intertwined to our public health system. And already in this law, it was established a mandatory public consultation for every process, every evaluation process that CONITEC holds. Afterwards, there have been a few improvements, changes, especially in 2022, but I'm going over that later. So how does CONITEC work? We have 3 subcommittees, one for drugs and vaccines, one for products, one for clinical products and procedures, and one for clinical practice guidelines. This is very recent, from 2022. Until then, we had one single plenary. And this is important. I think it was also a maturation process regarding that. At first, maybe we didn't have even enough maturity to split the committees into 3, technical maturity, management maturity, but over time we realized that we were able to improve our processes by doing so. And this division is based on the different logics that we have for financing drugs and vaccines and products and procedures. The responsibilities for financing and provision of these technologies is different. It's from different actors, and the processes for providing them are very different. So that's why we split into drugs and vaccines and products and procedures. And clinical practice guidelines are obviously very different from these products, physical products that we provide. And the Executive Secretariat is within the Ministry of Health, our Department of Management and Incorporation of Health Technologies. We are over 100 people now, and we also have partner HTA units. We usually do not elaborate the reports within the Ministry of Health. Our HTA units, our partner HTA units do it for us. Also for the clinical practice guidelines, they are usually the ones that do it. We are linked to the Secretariat of Science, Technology and Innovation, and of the Economic Industrial Health Complex, which is a secretariat of the Ministry of Health that fosters research, evidence-based research, and also the local production of technologies. So it is an innovation environment that this secretariat deals with and tries to foster. The composition of our committee. The 3 subcommittees have the same composition, and each of these bodies can nominate whoever they want, but there is a requirement since 2022, since this decree, that the people they nominate should have knowledge in HTA. We do not have mechanisms right now to guarantee it, guarantee they are complying with it, and actually indicated people that have experience with it. We are working on it. It's a work in progress, but we do believe that was an important change, trying to guarantee that people there have the ability to understand HTA. But at first, it was honestly not possible to do so because we did not have health managers enough that had this HTA capability. Also, we are trying to support the members of the committees with that. So we hire courses for our HTA network that are also offered to the members of the committees in order to help them out with improve their HTA skills. So there are 15 members. They'll nominate a primary member and 2 alternate members. We have members from secretariats, almost all secretariats of the Ministry of Health. Some of them deal with assistance, unlike our secretariat. So that's the case of CESAI, of the Indigenous Health Secretariat, specialized in primary healthcare. We have members from regulatory agencies, so the Agency for Private Insurance and Health Plans, Surveillance Agency, which registers every technology, instance of derivative agreements. So we have representatives from local health departments, state health departments, and municipal health departments. They usually discuss it previously with these representatives. These councils discuss it previously with all representatives from municipal and state health departments, and they take this position to the committee. Social participation, we have the National Health Council, which has representatives from health professionals, patients, and health providers. They monitor the Ministry of Health's actions and assist the Ministry of Health and even make some sorts of decisions. So they do have representation, and members of the Federal Council of Medicine. Since 2022, we have these highlighted members here. It was at the Brazilian Medical Association, which reunites medical societies, and members from the HTA unities as well, so methodologists from our HTA network. And also we have observer members since 2022, and this is very important because we have a huge litigation issue, and we are trying to bring judiciary system actors closer to us, so they are able to send observer members to participate on the meetings. They cannot vote, but they can even make a speech or something, and they do that. They do so sometimes. So that's our incorporation process. We have to do it within a time frame of 180 days plus 90 days. We can extend it for 90 days, 90 additional days. We usually comply with that deadline, and in cases such as COVID, we expedite it, but the documents are the same. We just do it within a shorter period, but the process does not change that much. We just give it priority. We do not have a prioritization process. In case you are, I understood that Kenya is trying to have a prioritization process. Argentina has a very good one, framework for prioritizing technologies. We evaluate everything that is submitted to us, actually. So we have external submissions from the industry, medical societies, patient advocacy groups, or any individual, anyone can do so. And we have internal submissions, so MOH areas that deal with assistance. They can request CONITEC to evaluate a certain technology. And also more recently, there was a decision by our Supreme Court that said that the judiciary branch can also request the MOH to evaluate the technology in case it is being too litigated too often, requested too often. but we did not establish a special process for that yet. We are discussing it with the Supreme Court. So in case it is an external submission, there's a critical evaluation of the report. In case there is an internal submission, we request the HTA Unity to prepare the full report. CONITEC analyzes the report. It goes through a public consultation, and it analyzes the report again with the amends or changes after the consultation. Then our secretary, he receives the report and evaluates the recommendation. He usually follows CONITEC's recommendation when deciding, but he can also request for a public hearing to happen so we can hear other actors that are involved, interested in that technology. But it really happens only more sort of let's say, controversial cases, in cases where it's harder for him to make a decision. It only happened 8 times. So for the decision-making parameters, we have several ones, from clinical parameters, safety, horizon scanning. There are other technologies coming into the horizon, economic parameters such as budget impact, cost effectiveness. We discussed organization issues, implementation issues, logistics, and also we have a patient testimony. Since 2022, we have a cost effectiveness threshold. It was a large process setting it. Since 2016, we've been discussing it. It was very hard to build something that was evidence-based. It was based in studies and largely discussed with society. There was public consultation, public hearing, etc. There was a huge pressure for us to implement it, and after we did, the industry is not satisfied that we did so, even though it was really evidence-based. But this is something, this is part of the challenges, raising awareness on it, convincing the society that this is an important process, and even health managers sometimes. We have some positive and negative modifiers. So the threshold, which is in 40,000 reais, it can be extended up to 120,000 reais if it's a rare disease, if it's a severe illness. But for severe illness, for instance, we do not have a specific definition, so sometimes it is still subjective. And the threshold, it's not the only thing that is going to be analyzed. There are other parameters that we also analyze. It's not, okay, didn't reach the threshold, it's not going to be incorporated. No, sometimes we have no therapeutic alternative, for instance, for that disease. Those patients require treatment. So this is always evaluated combined to the other parameters. But this was a very important advancement that we made during the years, but it was not easy. It was built during the years, something that its adoption, it's not simple. And even now with the committee, sometimes people have different perspectives of how it has to be implemented. I mean, the committee members. Social participation is something that we really improved at, and this is something we could have done earlier, maybe. Even though the public consultation was mandatory since the beginning, there have been important improvements. So since 2014, we have 2 types of contributions. So experience and opinion from family members, caregivers, and patients, and scientific opinions from people that are more HTA experienced. We still have the same sort of contributions, and the methods that we used to evaluate were improved. Now we have a qualitative analysis, for instance. There is a report for society. So we have a special report that is simpler, in simple language, to help society to understand the topic that is being analyzed, the indication and the technology, so they can send their contributions their comments to the public consultation with more inputs and a clearer understanding of that topic. We also have more contact with the pharmaceutical industries. We have a pre-submission meeting with them if they request so. And they also give a presentation when Conitec is evaluating the technology. They do not vote, they do not watch the voting process, but they can present their demand, their technology. And we have the participation of specialists and patients. We invite experts in that disease, and a patient that was that had a disease, that had experience with that technology, and that was maybe the most important change we've been through over the past years. In 2020, we made the first patient perspective call. So we published a call for that technology, and we have a registration of patients and associations. If so they receive they receive an email notification informing about the call. They can inscribe. The call is also in our website, so it's easy to access it. But many people do not know about it. That's why it is important for us to have this active research of patients throughout the registration, and also experts might help us on it. We had forums that reunited stakeholders that are interested in this process, patients, industry, judiciary branch, and etc., in which we discussed in 2019 and 2021 improvements that could have done, that we could do to Conitec. And many of the improvements we have been doing over the past years were actually came from these HTA forum meetings that we had. We had transparency as a principle at the public administration, so we have many transparency initiatives. This is something that we could have done earlier as well, but it is hard to understand what's the limits and how society is going to perceive that. But all of the meetings are recorded and published at YouTube, for instance, the appraisal meetings, I mean, the discussions, the full presentations, etc. It's all public. We have the minutes and topics of the meetings public as well. We have data on our evaluation processes. All the documents that are submitted by the industry to us to motivate a technology appraisal are public. So we are very transparent in our processes. And as I mentioned, the Brazilian HTA network is very important for us to be able to maintain that work in the long run. So we consider the bridge between research, policy, and management. They produce HTA reports for the Ministry of Health. They help us elaborating clinical practice guidelines and methodological guidelines. We foster research that in many cases are these HTA network, are these HTA unities from the HTA network that conduct. They help us out with courses and events, and we finance those courses and events and research and etc. In order to improve their technical capacity. There are over 129 HTA unities right now with over 1,000 professionals across the country. And we have a technical level categorization. We send them a form that every professional fills, and based on that form, we understand what's the technical level of that HTA unity, and we do so in order to plan actions. So we understand throughout that categorization process, what is their level in, for instance, technical evaluation, economic evaluation. Is that something that we have to finance courses on that area, for instance? And we also use that to hire our partners. So partners that are more advanced in their HTA capacity. These are the partners that we hire for helping us out with, as I mentioned, methodological guidelines, clinical practice guidelines, HTA, etc. So these are our methodological guidelines. Sorry, 1 minute. This is almost my last
Yes,
slide.
1 minute time.
So I know I'm advanced in time. We have over 20, actually. These are not all of those, but we have methodological guidelines for several topics. These are, in many cases, already an update of the first methodological guidelines. This year, we are launching the updates for budget impact and economic evaluation, for instance, the first edition for utility. So we've been advancing in new topics, as well as in addition to actually updating the last ones. So there are several processes after the incorporation. We have to understand who is responsible for providing the technology: federal government, state government, municipal government. Sometimes we have to create procedures. We have a purchase process. And for that reason, it is often very hard to implement the technology within the deadline in which we should do so, which also 180 days. It is very hard for us to work with this investment. It's hard for society to understand why this investment is important. They understand it as reducing access to technologies, but we believe it is important to improve the efficiency of the system. It is very hard for us to deal with high-cost technologies and low-quality evidence. This is something with gene therapy, for instance, and oncological drugs that is very challenging, and we're trying to find solutions for that. Litigation is a huge issue here. So as writers of constitutional health, people request technologies throughout lawsuits, and we have to provide them. We are working with the Supreme Court to reduce it, and raising awareness on the society that HTA is important, that they should defend it. It is important for sustaining the public health system within the long run. This is hard because people understand it as reducing access. So these are the main challenges that we have, things that we are trying to work to improve. And I had some data afterwards that were not as important. I think what we could have done differently is basically transparency and social participation that we could have worked with earlier. But it was a process of developing our technical capacity and institutional development as well. So that's it. Thank you. If you have any questions, we are available also afterwards if you want to send us anything after the webinar. Thank you.
Okay, great. Thank you very much, Barbara, for this. All of our participants know we are a little bit above the time, but considering that the topic is very interesting and we really wanted to have this webinar session, I will then maybe prioritize the questions that the Kenya team would have. On the interest of time, I would say maybe Dr. Tabitha put one burning question for the Philippines and one burning question for Brazil. And then I'll give you the floor to you. Thank you.
Thank you, Georgina. Thank you, Yen and Barbara. I think there's a lot of learning points from Philippines and Brazil for Kenya. Actually, narrowing down to one question is a challenge, but let me try. So maybe for Dr. Barbara, I would like you to highlight the challenges that Brazil has had in conducting health technology assessment when you're considering public and private sector, and how the Brazil population take up the HTA evidence that is generated for the different health sectors, the public and the private. And then for Philippines, I'm interested to know what the fluctuation in HTA evidence numbers over the years, what informs that fluctuation? Is it the number of topics that are nominated or proposed to be assessed, or is it the availability of funds? Why do you have some years that you produce little evidence and some years that you produce no evidence? And probably for both of you, just quickly, I'm happy that I've seen, I think it's Brazil. You already have a threshold for the economic cost effectiveness threshold for your country. How do you then collect health outcomes? How do you collect your utility values to determine qualities for the interventions that you're doing? Is it done routinely with health data, or do you have to do separate research for that? I think that should be it. Maybe, Georgina, if you'll allow me, I have a question for Althea.
Sure.
And I think she shared learning lessons from other countries on what they're doing on HTA. And I'm interested to know, for the countries that have been able to successfully institutionalize HTA, how do they fund their HTA process? How do they resource mobilize? Does the government take the bulk of the funding, or do they, like, who funds their HTA processes and operations? Thank you.
Thank you very much. Maybe I give the floor first to the Philippines. Welcome back, Yen. I hope all good from your side. We lost you before, but we appreciate a lot your presentation.
Thank you so much, Georgina. Thank you also, Tamisa, for the question. So for the Philippines, the question is about the fluctuation of number of assessments produced, right, per year. Right. So I think basically there was some peaks during COVID-19 because we were, as mentioned earlier, using an expedited approach. There was a peak in 2022 because that was the peak also of the national government to really submit lots of topics, particularly vaccine policies. We were trying to really see which particular COVID vaccine should be introduced nationally. There was another peak in, I think, 2023, because that's also the first time that we introduced an accelerated pathway for technologies that are already considered standard of care. And it was mostly driven also by the priorities from the Ministry of Health, because that time they wanted to introduce or create the Philippine Essential Medical Device List. And because there was a push to catch up with the national formulary, which already have listed, so many drugs, because that started about 20 years ago, there was a push to come up with a quick algorithm that will approve many essential medical devices that are already standards of care in the CPG, regular consumables, and devices in hospital. And then there was a bit of slowdown after that, because that was the year when we started transitioning to the Department of Science and Technology. But right now we're trying to catch up again, because there were a lot of conversations again with the Ministry of Health and the National Health Insurance Corporation on how we can streamline better our processes and maybe prioritize low-hanging fruits, topics that do not really have to undergo full HTA because they're already either standards of care or technologies that are of long-standing use in the market. And then maybe introduce the more expensive, innovative technologies after this batch approval of these technologies. Thank you. Over.
Thank you. Thank you very much for your response. Maybe we can now take the question for Barbara, or the questions.
Yeah, I remember the questions about the public and private issue, right? Well, as I mentioned, they overlap the coverage of the public and private health systems. it is all very technical discussion, and people do not really know about Conitec and about INSS's process for HTA as well. They only know that when they are trying to use something, sometimes it is not covered. But when it's not covered for the private health system, for instance, they usually litigate. So they use lawsuits to request it to the public health system. So they are still assisted if something is not at the private health system. So usually when it's something very expensive, it is the public health system that pays for it. But naturally, there are some things that are more advanced. There are, for instance, oral oncological drugs that are only at the private health system. Our understanding at the Ministry of Health is that this is natural somehow, because people are paying at the private health system, so they should have access to things that are different to more, at least to what they have at the public health system, as we are trying to cover the full population. So people do not deal well, I'd say, with those differences, but they do not understand where those differences come from. They do not know about the existence of different HTA processes unless they are very involved in patient advocacy or public administration. Unless they're really involved with it, they do not know about it. There have been discussions about unifying those two HTA processes, but for us in Brazil, I do not think, we at the Ministry of Health actually do not think this would be feasible, because the coverages are different. The technologies that are available at those two systems and the logics are different. We evaluate everything for the whole country at the Ministry of Health, and we have the Ministry of Health's participation in the financing processes. We have budget for purchasing technologies. It is very different from how private health insurances work. So economic evaluation is different. The comparators are different because the coverage is different in the two systems. The way of purchasing the technologies and providing them is different. So it is very, very hard to unify those things. But that's the solution that somehow some people are trying to push for. Again, we do not believe that's a solution for our case because they overlap. But maybe for Kenya's case, in which they provide different things, this would be a possibility. But that's it. People do not know about those differences. They experience them when they are trying to access a service. And if they cannot find it in the private, they request it to the public via lawsuits.
Okay, thank you, Barbara, for your answer. Althea, please, go ahead.
Yes, thank you. So I think the question was who funds HTA? I think in most cases, when I look at the case studies that we did, for instance, in most cases, the funding is public funding. And as I said in the presentation, this is directly related to the stability of funding, is directly related to the regularity of the process, how regularly are assessments produced, etc. Then what we see is that in some countries, there is donor funding. There are few models where there are private sector contributions, or they rely on industry submission fees. In most cases, this is not the case. The model that we see most often is reliance on public budgets.
Okay, I think it was very clear. And colleagues, we are already 30 minutes beyond the established time. We want to appreciate all of you that have been holding much beyond the time, but it was worth it because the country examples were very interesting and a conversation as well. So thank you very much once again. And this is the last webinar sessions that we have in this collaboration between the Ministry of Health and WHO on implementing social health insurance. But before concluding, as we usually do, very, very briefly, and before concluding, as I'm saying, I will give the floor to each of the speakers just to give one sentence. What is the main takeaway that you would like to give to all of us? And like this, then we will conclude the session and the webinars. May I ask first, maybe Altea, what would be your main takeaway?
I mean, thank you, Georgina. To summarize what I also put in the Q&A, I think my main takeaway is building the awareness for how important this process is to drive the reimbursement decisions in terms of removing the subjectivity of the decisions and making the process more fair and more transparent and based on evidence rather than individual preferences or opinions. Thank you.
Thank you. Dr. Yan, what would be yours?
Everyone. So I think for me, it will be very important that the core of how we implement HTA will be a strong stakeholder engagement. I think the easiest part would be establishing the objective parts, but getting the buy-in from the stakeholders, being transparent, and getting their strong support will be the biggest and most important, because that way, even if you may have disagreements on how the evidence was seen and translated into recommendation, but if you agree that the process was transparent, if you agree that the process was fair because everyone was consulted, then at the end of the day, everyone will support the recommendation from HTA. Thank you.
Thank you. And yours, Barbara?
In Brazil, having Conitec as part of the Ministry of Health, which is responsible for guaranteeing the implementation afterwards, linking everything within the public health system, we believe that is very important as a step to guarantee the implementation, which is still a challenge, but if it wasn't done in that way, it would be even more challenging. And it also guarantees that we do have a budget. The fact that we are connected to the Ministry of Health guarantees that. And in the fact that the HTA process is the public health system's law. Regarding our process, I think what we could have done earlier are some improvements in transparency. We've always been transparent throughout our website, but for instance, providing the records of the meetings, things like that, we could have done earlier. And mainly the participation of the patient at the committees with their testimony. That was a big shift for us and something that was very important to work at. Yeah, I think those were my highlights. So thank you.
Okay, thank you. And from the ministry or from the Kenya team, Tabitha, what would be yours?
I think the ministry team had to go for another meeting, but I think from all the sessions that we've gone through, the series of webinars, what comes out very clearly for Kenya is every country needs to adopt what works for them according to the health system. And there's such a variation, although everyone is conducting health technology assessment, the modalities, the structures are so different. And really, we need to anchor our processes and our structures based on our priorities, based on our legal framework, based on how our health structure is. And also, I think more importantly, Dr. Yen and Barbara have stressed this so many times, the involvement of stakeholders. I think as we are setting out as Kenya, we need to just figure out how, get the buy-in of the industry players, make the process as transparent as possible, be able to share as much information as possible about the HTA process and the decision-making process. So I think as we chart out our path as Kenya, big lessons to learn, but also structures need to be put in place for all this to be considered and taken care of. Thank you. Above all, we just want to thank the countries that have been able to, give their time to us and to share their experiences with us as learning lessons for us. I think this is giving us very good insights on what we need to consider and what we need to do. And hopefully it will help us chart a good path forward. And we are hopeful that we can still reach out to you even beyond this webinar, to be able to discuss more and, to learn from you, to get guidance and, just to share experiences as well. Thank you so much.
Thank you. And exactly what just Tabitha said, our appreciation to your time, all of you. And we will keep in touch and continue these discussions. Thank you very much. Thanks to all of you. And the session is closed. Bye-bye.
Bye. Thanks.